Hello, everyone, and welcome to this episode of Let's Talk. Really excited to have the conversation today. My guest on the show today is Dr. Greg Tees. He's the Chief Medical Officer at AMITA Health in the Behavioral Medicine Service line. I'll give a little bit more of an intro in a second. In the meantime, I want to encourage everyone, please come with your questions. It's not every day that we have an opportunity to chat with someone like Dr. Tees. I know I'm really excited about the different areas that we're going to speak about today. I'm just personally very interested, and I have a feeling you are too. So please feel free to ask them, and I'll make sure that I'll put them up on screen. We'll take the questions as we go. But he is a psychiatrist, chief medical officer at AMITA Health in behavioral medicine. He oversees all of the behavioral medicine services across all 8 hospitals at AMITA Health. He's the former president of the American Academy of Clinical Psychiatrists. He's currently on their board of directors. He is a legendary, in my opinion, here in the Chicago community. He's been working here for quite some time. So thank you so much, Dr. Tees, for coming on the show today.
Great to be here. Thank you, Aaron.
Yeah. So if you could start us off just telling us a little bit about what you're up to right now at AMITA. What are your current projects? What's new?
Well, as you can imagine, we're doing a lot of administrative issues because of our merger between AMITA, which was actually Advent Health Chicago, as well as the Alexian Legacy hospitals, with the Presence hospitals. So we now have 18 hospitals. 12 of them have psychiatric units, and so over 600 beds. So it's a busy project, and we're doing some interesting work in formulating a behavioral medicine IPA. And my passion still is very clinical, so I like getting involved with addiction medicine as well as integrative care, where we work with primary care physicians.
Yeah, it's kind of hard to even wrap your mind around 18 different hospitals. That is more than a baseball team of hospitals.
It certainly is.
You could field almost both sides of the field, but it's a lot to think about. But you guys are achieving some pretty incredible things. So I'm really happy to have you on today. So our topic for today is modern psychiatry. And so there's some practices that you're doing right now that are very much on the cutting edge. There are some just practices in general that we wanted to talk about today that I think are either lesser known or there's some misinformation about that we might be able to clear up. So what I wanted to start with, though, was an area that I know that you're passionate about, is about how to do a rapid opioid detox to potentially get people onto naltrexone. So maybe you could start us off just by talking a little bit about what naltrexone is, why people would want to get onto it, why doing this rapid detox. What do we need to know?
Absolutely. So we're really talking about people who suffer from opioid addiction and opioid dependency if they have chronic pain problems. So our subject audience would be people who want to get clean, come off of opioid therapy, get onto a blocking drug like naltrexone, which blocks the opioid mu receptors rather than stimulates it, such as morphine and heroin do. And the rapid opioid detox allows us to do this with outpatients within a 4-day time span, as well as inpatients in 3 to 4 days, which is quite unique and quite useful, because otherwise it would take probably 2 weeks of being in a residential treatment program to achieve the same. Mm-hmm. The chronic pain patients come to us largely from their doctors who are no longer willing to give them opioid therapy due to their high dose use, or sometimes due to aberrant behaviors that led them into trouble with violating pain contracts. So surprisingly, most of our outpatient detox patients have turned out to be chronic pain patients.
Mm-hmm. Yeah, well, and to be honest with you, I'm even right now working with some folks going through an opioid taper slowly and just trying to do it by coming slowly down off of the agonist opioid medications that they're on right now. Why is it useful then, in your opinion, to completely taper down off of opioids and move to naltrexone versus go to more of a maintenance medication that is still an agonist, like Suboxone or methadone or something like that?
Well, currently, all 3 of those choices are prominent in the treatment of opioid dependency. And so I don't prefer one over the other. It's an option for what our patient desires to do. So sometimes patients have been on Suboxone in the past. They don't stay on the medicine. They get into trouble and they come back. And same thing goes with methadone. So they're looking for a different pathway. I would say most people probably don't want to start with antagonist treatment. People mostly prefer agonist therapy, as you mentioned. But the other interesting thing about rapid opioid detox is not only do we get people off fast, but it's more comfortable when they finish the process. When I do slow tapers, patients are miserable. They're complaining, they're uncomfortable. We go through weeks of this agony that they're distressed over. And when we do the rapid opioid detox, for a reason I cannot scientifically explain, the patient feels quite robust at the end of that process and is very happy with it.
So what do you think is the reason why we don't hear about people doing this very much? I think that, like, when I think about what people do most often when they're trying to come down either off of legally obtained opioids, or if they're trying to stop illicit use, heroin, pills or otherwise, we're oftentimes thinking about going into detox or doing that really slow taper like you described, or even doing an induction in a medication-assisted therapy clinic. So what do you think is the reason why we don't hear more about this more rapid detox option and then on to something like naltrexone?
Well, for one thing, it's challenging because what you have to do is answer a lot of questions from the patient about what they're going to experience, what are the downsides of it, which is uncomfortable spell of time that lasts about 36 hours, and what we're going to do to protect them from the discomfort of the withdrawal process. And for that, we use different comfort drugs. So we tend to use drugs like gabapentin, which helps anxiety and helps withdrawal. We help with the use of quetiapine or Seroquel, which is a sedative, so it helps people sleep at night and feel calmer during the day. And clonidine, which is an alpha-2 agonist, and that helps people just feel more comfortable with their withdrawal process, which was all we had to offer patients before the rapid detox came about.
Yeah. Yeah. Well, so, and I know that fear of withdrawal and that discomfort is a really strong force that keeps people from wanting to stop potentially at all. What sort of approaches do you use to talk with folks who are on the fence or who don't know if they want to pursue that option, or who are thinking about doing more of like a medication-assisted therapy? What helps them better understand that this might actually be a good or even better option?
Well, I think the key thing is being open with people. In my experience with chronic pain patients, although they've been on opioid therapy generally for 3 years or more, they're very tired of being sedated all the time. They spend much of their day on the couch. They've lost friends. Their family is alienated from them because they feel that they're just sedated and unable to communicate effectively all the time. So the patient is at that point rather desperate and fed up, and they want a different change of life. So that's a little easier to deal with. Somebody with, say, heroin addiction is more challenging because it's saying, well, you mean I can never use again? I can never get high again? That's the commitment I'm making. And I say, no, we're not talking about that. We're talking about making an initial commitment of 3 to 6 months. Mm-hmm. If you don't like it, you're not happy, go back to whatever other form of treatment you wish, but give it a chance and see what happens. And surprisingly, the patients like it.
Well, that's a phrase actually that I use a lot in my work when folks are feeling uncomfortable going down any sort of treatment route, is the idea that you can always get back to where you are. You know, nothing's permanently changed. If you want to get back to this, you can get back to this. And most of the time, you know, there's a reflective moment and people think, well, I actually really don't like where I am right now. And maybe it's worth trying something new.
And I would like to add also, Aaron, we use compounded naltrexone, because if you take the naltrexone tablet, which is 50 milligrams, and break it as small as possible, which is usually in eighths, that's 6.25 milligrams per dose. That's too strong in my experience. When I used to use that dose on patients, I'd have a 50% dropout rate. We now use compounded naltrexone in a liquid form, 2 to 3 milligrams per dose, and the patients tolerate that quite well. And if they do have addiction and they want to have a clean life from opioids versus chronic pain patients, we strongly advocate for depot naltrexone once we finish the process. So that seems to be a more scientifically, if you will, advocated method of using naltrexone in the oral form, which people do not comply with uniformly.
Yeah, and for those who aren't familiar, so depot naltrexone is an injection, so it's something that ends up lasting 28 days, right? Is how long that lasts?
That's correct. There might be a small number of people who are rapid metabolizers, and they could need a shot every 3 weeks, but the FDA-approved use of the drug is for 28 days.
Yeah. And so it's very useful if you're thinking that you might have some wavering commitment or compliance issues, like you're talking about, not actually take your pills every day. And I know for me, I'm very interested in how do we get more naltrexone involved, because, and we've kind of alluded to this in the conversation so far, people struggle getting off opioids without some sort of medication. It's possible, but some of the studies that have been shown indicate that up to 90% of folks are going to relapse within the first year if they're not using some form of medical assistance. And the other options we have are other opioids, essentially. And while they're still vastly preferable to anything that you would be doing illicitly, or if you're misusing the substances, it still is taking an opioid, which has that same issue in terms of potential withdrawal if you stop, and you're kind of tethered potentially to clinics, whereas naltrexone can sometimes be, if you're stable on the psychosocial side of addiction, it can be a little bit less invasive into your life, and it's got that added benefit of that you're not actually using an opioid. You're just blocking those receptor sites with something.
That's a good point, Aaron, and I would think you and I both are familiar with the fact that many of the leading addiction centers in America have converted over to medication as treatment. We used to call it medication-assisted therapy. That's probably no longer the proper way to interpret the MAT acronym, but medication as treatment. And the reason why so many facilities converted over to this was the death rate of people coming out of the hospital or the residential program clean and sober, if you will, but unfortunately relapsing, not knowing that their tolerance had dropped so much, and taking an old familiar dose of heroin, if you will, that they used to tolerate, but now it's deadly because they've lost all their tolerance to the drug. The other interesting thing is, on our chronic pain patients, we will at times leave them on a low dose of compounded naltrexone, and we're now seeing articles appearing in the medical literature about low-dose naltrexone for pain. I use it on several of my patients for fibromyalgia at compounded doses, and get relatively good results. So it's an intriguing molecule I think we're going to hear a lot more about in microdosing in the future.
Yeah, well, and I think that we're going to talk on psychedelics in a little bit, speaking of intriguing molecules. But yeah, I guess to cap off my thoughts on opioids, and if you have anything else, I'd love to hear your thoughts as well. Right now, one of the most alarming statistics of, we'll call it the sequelae of COVID-19, has been the uptick in addictive behaviors and relapses, and opioid overdoses in particular. Depending on the part of the state you're in, we're up 30 to 50% over last year here in Illinois, where we're based, which is really alarming. Really alarming. And so I think more than ever, it's important that we have all of the tools in our belt to combat the opioid epidemic, to get people help, to get them safely in a program, or get whatever help they need to keep them safe. And I think this idea of doing a rapid detox, being able to more easily access naltrexone, because, and I'm not sure if we mentioned this, normally you have to be off of opioids for 7 days to start naltrexone. That's kind of like the standard idea, is you're off of all opioids for a week, but that's really hard if you have been on opioids for a really long time. So having this tool available to get people on it more quickly, I think it's essential.
Yes, and one of the things I think you and I have talked about in the past is we can also get people off of Suboxone therapy once they feel that they're ready to convert to an antagonist treatment. It's perfectly legitimate to think of long-term treatment on agonist therapy such as methadone and Suboxone, and many experts strongly advocate for this. Unfortunately, patients don't follow that path. They want to do their own thing, and once they're stable for a period of time, they don't want to be tethered to an opioid. And at that point, we don't want to just withdraw them and leave their receptors free to further exposure, because that's dangerous for them. But if you convert them over to antagonist therapy, for probably a year, maybe longer, before discontinuing therapy. It can give them a chance to see what life is like without their mu opioids being stimulated.
Yeah. I really appreciate the level of specificity and expertise that you bring to this, because I think that a lot of folks who are going through addiction, opioid or otherwise, I think they don't understand how much research, time, effort, and learning has gone into treating addiction on the medical side, because a lot of the addiction treatment and recovery sphere is separate from that. That there really is so much benefit to be had if you're struggling, and that reaching out is incredibly useful.
Particularly during this time, as you've noted, the CDC is now reporting on climbing death rates for opioid overdose. The most latest study showing June of 2019 to June of 2020, 81,000 deaths. So we used to say the death rate was a 3 to 4% of heroin addicted people per year. Because of the use of fentanyl in compounding heroin now, the death rate is up to 6 to 8% per year, which is terrible. I mean, you can't imagine how devastating that is to people and families.
Yeah. I mean, it's in our line of work, you hear about this all the time, but it never gets easier. It's always a tragedy.
Absolutely.
Yeah. Well, let's pivot for a second to another topic where you've got some interest in areas. I think that when someone's suffering from it, that it's not only a really big deal, but feels pretty hopeless, which has to do with treatment-resistant depression. So this is something where if someone has depression and they've been trying to work on it either with just psychotherapy, or we'll call it standard first-line medications for depression, like SSRIs or SNRIs. Some of these is very frontline approaches, or even some adjunct ones. That it hasn't really been working. We have all of these treatments right now that are purportedly helpful, some of which we've had for a while, things like electroconvulsive shock therapy or ECT, some that are a little bit newer, some that are even controversial. And I just wanted to get your take on, for you in your practice, when you're encountering someone who has this sort of really recalcitrant depression, just not moving, what are the tools that you like to lean on the most, and why?
That's a great question. We're basically talking about major depression, which is pretty clearly defined in the DSM-5. And the elements of that have to be present for at least 2 weeks in a row. Now, for people who have major depression, the average length of time is probably 6 months to 18 months before recovery. But about 30% of people with chronic major depression never recover. They may get a little better, but they have a devastating, disabling illness that leads them into a long-term state of problems. Now, the treatment-resistant depression means you failed 3 to 4 treatments. And the biggest reason why people don't get better with treatment is they take too low of a dose of medicine, or they don't take it consistently for at least 4 to 6 weeks. So if we've ruled that out and the patients have complied with treatment successfully at an adequate dose, and we've used different types of drugs, say a SNRI such as venlafaxine or duloxetine, or a SSRI such as sertraline, fluoxetine. We can use atypical agents such as bupropion, which is Wellbutrin, or mirtazapine, which is Remeron. So using those drugs as alternative options or in combination with some of the other drugs, which is commonly done, we establish a state of treatment resistance. And I would have the listeners kind of imagine what's happened in psychiatry, is what's happened in treating high blood pressure over the course of years. We used to be satisfied when people's blood pressure got down to maybe 150 over 90 to 95 and say, gee, that's a lot better. Go on your merry way. We now know that leads people to have a significantly elevated risk of stroke and heart attacks. So we have much lower levels we want to get people's blood pressure to. And that requires 2 to 3 different drugs frequently. So there's nothing wrong with polypharmacy in treating depression if that's what it takes to get better. Mm-hmm. Of the treatment-resistant cases, we're talking about 70 to 80% of people respond to standard treatment, but 20 to 30% become treatment-resistant. And we have adjunctive agents. We can use what's called thyroid T3, which is trade name Cytomel. And this is an adjunctive treatment with people who have even normal thyroid functioning, but it's in the lower 50th percentile of the normal range. We can add lithium carbonate to some patients, and that can be quite useful. We can try, certainly cognitive behavioral therapy should be part of the trials before you consider it to be treatment resistant. And if all of that has been tried, then we have other options available. Transcranial magnetic stimulation has recently been approved by the FDA and is now expanding some of its uses. Electroconvulsive treatment's been around since the 1930s. And although, unfortunately, one flew over the cuckoo's nest has given that a very bad reputation, ECT is widely used in America and is probably underutilized because it has such a high success rate. About 85% of people with treatment-resistant depression may respond to ECT. So very nice results. People who suffer from what's called psychotic depression, where not only do they have symptoms of major depression, but they also may be hearing voices who belittle them or humiliate them, or they may be having visual hallucinations, oftentimes seeing small creatures scurrying out of the corner of their eye, are classical kinds of forms of psychotic depression. And ECT is probably the treatment of choice for psychotic depression. We also have people who develop catatonia as part of their depression. And some of your listeners may be aware the catatonia is most commonly in the akinetic state, in which a person is losing their movements. They may have waxy flexibility. They may not communicate. They may refuse to eat. And that could be a life-threatening condition. And so ECT is quite effective with catatonia as part of a severe form of major depression.
Yeah. So question. So we've got different types of severe depression or treatment-resistant depression, and we have all of these methods. And you touched on ECT. You mentioned transcranial magnetic stimulation, TMS, and then we also have the ketamine and esketamine potentially treatments that made a splash a little bit ago when esketamine got approved by the FDA. How do you decide? Is there a certain sort of depression that's treatment resistant goes in a certain direction, or how do you guide folks towards the treatment that's actually the best one for them when it gets to this point?
Well, I think the consumer must have some caution in this area. There are individuals who are setting up ketamine treatment clinics. Now, ketamine has shown some interesting utility in the treatment of chronic pain syndromes, particularly neuropathic pain. So ketamine has a variety of potential uses, whether it's FDA approved or not. It is not FDA approved for treating depression. And some of the clinics that use ketamine are not run and operated by mental health professionals. And so it has to be used with, the consumer must have some caution as to where they're seeking care for this. Esketamine is an interesting drug. So it's ketamine, like so many other drugs, is a racemic mixture of mirror image molecules. So esketamine is one half of that racemic mixture. And that is now available in an FDA-approved treatment intranasally that can be given in a clinician's office. It's a rather exotic setup because it requires about an hour of administration with the nurse present. And the patient administers the ketamine themselves by applying it inside their nose. And then they have to be monitored because ketamine can increase blood pressure. It can cause an incidence of depersonalization of about 3 to 6%, which can be quite frightening and lead to panic-like states for patients. So ketamine has a downside we have to be aware of. Mm-hmm. That being said, we can see some remarkably positive results with esketamine. So sometimes patients will come out of their depressed state within days or hours of administration of the drug, which is highly unusual. Most antidepressants take 2 to 4 weeks, as you know.
Yeah, you've got to wait for that reuptake aspect to build up a bit. Well, so you mentioned earlier when we were talking about ECT, that it's actually incredibly effective in many cases. That even up to 85% of people may get a significant benefit. You also mentioned how the depiction of ECT in the media and in movies has been really counterproductive to people doing it because they get scared. You know, they've seen One Flew Over the Cuckoo's Nest. Maybe they've seen A Beautiful Mind. You know, it's never really viewed or portrayed in a particularly compassionate way. And so I think that might, I know I've talked to some folks who have been very scared of that and said that they would not do that. They would not consider that.
Yes.
What is modern ECT? Like if we throw the media stuff out, like what actually is it? And is it something that we should be scared about?
Well, unfortunately, Aaron, I think we're stuck with a terrible name. The name itself, electroconvulsive therapy, and some people say electroshock therapy, is enough to frighten most consumers away from wanting to go that path. What actually happens is it's like a minor surgical procedure. So if you've ever gone through a colonoscopy or a gastroscopy, you go into the doctor's surgical area where you're given an IV to start some fluids going. You're taken in front of the anesthesiologist who gives you a drug that puts you to sleep for about 3 minutes and then paralyzes your muscles for about 2 minutes while you're under sedation. And during that 3-minute interval, the doctor applies some electrodes to your forehead and you get a brief impulse that causes a seizure-like activity, but you don't really see a seizure. And the patient doesn't have any of the risks of seizure because of the muscle relaxation. And that lasts about 20 seconds. And then the patient wakes up and they go to recovery room for half an hour. Usually the patient has no recollection of the treatment at all. And I warn people as part of the consent procedure is that when you go through ECT, you will have these Swiss cheese lacunae in your memory of the days of ECT. So you may even weeks or months later not remember the day you had ECT or part of that day. But there's no unpleasant memory because of the anesthetic agents being applied. Yeah.
So it's something you're basically asleep for it. You definitely don't remember it. It itself is not a dangerous procedure at all. It's just kind of got a scary name. It would be better if it was just kind of like warm, fuzzy buzzing therapy or something like that, you know?
Right.
But brain massaging with electrodes therapy, you know?
Yeah. I like the term neurostimulation. But we have to come up with something better than ECT.
Yeah, neurostimulate. That almost sounds like Bradley Cooper in Limitless. You know, kind of like simulation. That's what we're doing. All right. Well, that's helpful and hopefully helps people understand. Like this isn't the sort of thing where you're like biting down on a popsicle stick and shaking all over. And you know, like this is actually something that's very controlled, very safe. It will not be, you know, the actual process of going through it is not scary.
Not at all. And the professionals feel very comfortable administering it because of the safety involved in the treatment.
All right. Well, so let's talk about another side of depression that I know you're also very interested in. And that being when people might not even know that they have depression, but know that something is wrong. And that's something I know when you spoke to me about it, I had not thought about this very much. Something called masked depression, or otherwise known as somatic depression, where it's might be presenting in ways where people don't really know that they're depressed in the first place, but really that's what's going on. They could use some help. Could you tell us a little bit more about that?
Absolutely, Aaron. So this is a very interesting area in psychiatry because most people who have major depression walk into a psychiatrist or a therapist's office and they say, I'm depressed, I need some help, or I'm anxious and I'm depressed also, or some combination of that. Mass depression presents in the primary care office primarily. And this is when the patient comes in and says, I've got this headache that's been bothering me for the last 3 months and it's not going away. Or I have abdominal pain or back pain. Sometimes it could be another form of chronic pain. But the patient is plagued by this. They see multiple specialists. They don't get any answers. They don't get better. And because they're complaining of somatic conditions, the doctor may not ask about depressive symptoms, but they do have the symptoms of major depression. They have mid-nocturnal or early morning awakening. They may have reduced appetite and weight loss. They can't concentrate or focus their thoughts. Their energy is low and they're neglecting activities, their daily life. But they don't recognize this as depression. They think it's part of a physical syndrome that's sapping them of their strength. It's estimated that as high as 30 to 40% of all patients who present in the primary care doctor's office with mass depression with major depression have mass depression, and they're seeking a physical cause for their symptoms, whereas only 5 to 6% of people who present in a psychiatrist's office have symptoms of mass depression with major somatic features.
So let me ask you this. So because it's kind of tricky, right? And it's presenting as some of these more mild somatic complaints that you might go to a primary care doctor for. And primary care, actually, I know I was shocked when I learned this a few years back, but they actually prescribe 80% of all psychiatric meds. I mean, they're very much where people tend to go first when they do identify that they're having depression. And they try to handle as much as they can before referring out to specialists. Where would you say the burden of detection lies on? Is this something where we need more psychiatry or behavioral health training for PCPs, primary care physicians? Is this something where it would be better to educate the public that this might be mass depression? I mean, what do you think?
Well, fortunately, one of the good things about the electronic medical records that are now pretty much universally used in primary care offices is that they enable you to have certain tools for diagnosis. The PHQ-9 is a nice screen. It can be administered in a very brief period of time and can give you important indications about whether the person may have depression when they present with somatic features. So they can administer these tests to patients in their office, or the nurse can, while they're waiting to be seen by the doctor. So that can be very useful. Mm-hmm. One has to remember that with somatic depression, one of the reasons why we have this condition is because people oftentimes have negative feelings about having a mental illness. Mm-hmm. The idea of being depressed is unacceptable to them. And so if you say, I don't think you really have a problem with migraine headaches, as you've been told before, what you really have is a form of depression, the patient oftentimes will not be very happy hearing that. So you have to know how to couch your diagnosis and treatment plan with the patient so you don't offend their own cultural or personal sensibilities.
Yeah. I mean, it's amazing, though, how much impact the mind can have over the body and vice versa. I know that there was a specialist back when I was working in Michigan who is focused entirely on psychogenic non-epileptic seizures, which for those who are not aware is when you're having what looks like a seizure, but you do not have electrical seizure activity in the brain. It's completely psychogenic. It's just done by the mind. And I've everything from that to IBS symptoms to, I mean, there's so many ways that if you have a psychiatric condition that you're not able to really grapple with or express properly, that it comes out physically.
Very true. And we have an area that many psychiatrists are interested in our field called medical psychiatry. And it is that interface between medicine and psychiatry, which is, as you've pointed out, can be quite considerate and perhaps as many as 50% of individuals who go into the primary care doctor's office will have a psychiatric condition of some sort that can be diagnosed by detection methods.
Yeah. Something else, while we're on this topic of the mind-body connection and mask depression, something that's caught my eye recently has been the evidence around acupuncture, actually, in some psychiatric conditions. And this was something that when I first heard about it, I was very skeptical, but then I actually poked around, no pun intended. and there's actually some evidence about this. And so I was just wondering, from your perspective in your practice, as you've been doing this here in the Chicago area, have you seen many of your patients try that route where they're working with a licensed or registered acupuncturist, and where they've seen some benefit, or what's your take on acupuncture or some of these alternative therapies that actually do have some amount of evidence base?
Well, acupuncture or acupressure has been applied in a number of conditions, and there's many reports in the literature. Unfortunately, we don't have a lot of large multi-center double-blind controlled studies, and so finding where the evidence leads us is difficult to say. There's been some utility of acupuncture in treating nicotine dependency and maybe other forms of chemical dependency that has been reported, and so I think it's of interest and needs to be explored more. In the field of psychiatry and most of our common conditions, such as anxiety disorders or mood disorders or even psychotic disorders, I'm not aware of any convincing evidence that acupressure or acupuncture has proven useful there, but certainly it'd be nice to have some studies to investigate that further.
Yeah, absolutely. And I completely appreciate that perspective. I know that I, in my work, tend to be very conservative and not actively promote things that don't have a strong evidence base behind it. Or if I do, I make it very clear, hey, this is kind of experimental. This may work. This may not work. Just know that going in. But it's just interesting sometimes to see how everyone has a different take with their own, we'll call them like biosystems that they're leaning on. I think if you asked an acupuncturist, like, why is this happening? Sometimes I think that they would talk about some like hormone or neurotransmitter released and what the stimulation and, the slight punctures do at a physiological level. But I also think, that the Eastern tradition that it comes from really puts a different theory forward for how this is actually impacting the body that has more to do with energy and flow and some things like that we don't necessarily talk about as much in Western medicine, but actually in some cases, like you were saying, does have some evidence that looks like a little bit stronger than others.
That's a good point. And there's been some indication that acupuncture can release endorphins in the body, which can be therapeutic in different ways. Those are intrinsic molecules that we know affect the opioid system in the brain, but we don't really fully understand all the things they can do. And some of the effects of acupuncture can be blocked by using drugs like naltrexone or naloxone, which are opioid blocking agents.
Interesting. Well, so getting back to this question of mass depression, so if someone were wondering, like, is this what's going on with me? If they're having some maybe like diffuse somatic complaints, or if they know someone who just always seems to have something going on and it seems like their mood, like they're wondering about this, at what point is this worth bringing up? Like, hey, you might want to talk to your physician about this. You might want to go get this checked out.
Well, that conversation can be difficult because of the person's own cultural feelings about mental illness in particular. So the idea of depression or other forms of psychiatric illness can be something that the individual does not want to identify with at all. I would kind of frame it that let's have you go see your primary care doctor, and I'd like your permission to talk to your primary care before the visit so I can tell them why I would like you to see them. And you can debrief the primary care about your concerns and let them be more discerning when they see the patient as to how to handle those complaints and how to consider other options that might be useful. You mentioned irritable bowel syndrome earlier. We know that some forms of irritable bowel syndrome do respond to antidepressant therapy. So the problem is, which patients do you select for the proper treatment? And that's a very difficult process. And the primary care doctor is the best one to involve in that decision making. Yeah.
Well, so that actually leads me to my last question while we're on this topic, which is one that I know I get a lot as a psychologist and as a therapist, is when people are wondering, should I be going directly to a psychiatrist, or should I be going to my primary care doctor first? Because I think that sometimes people feel like, anything psychiatric requires a psychiatrist, or if it's not that, there's this question of, well, I don't really want to get someone new on the care team, or it's going to take me 2 to 3 months in the Chicago market to get in to see a psychiatrist for a new patient visit because there's such a shortage of care. From your perspective, how should someone who either is thinking about this for themselves or for their child, how do you make that determination? Should you always just go to your primary care doctor first, or at what point should you consider transitioning, regardless of whether or not the primary care doctor is the one to bring it up?
Well, I think in a perfect world, if you will, going to the primary care would be the place to start. And that's all, as you mentioned earlier, Aaron, now primary care doctors are prescribing 80% of all antidepressants. Yeah. Psychiatrists felt threatened by that initially, but now we're grateful for it because many people do get better with that first treatment or two. Up to 40% of patients will have a robust positive response to the first antidepressant used. And so they don't need to go on and see a psychiatrist. They can get care locally. We should be looking at our efforts as more able to help those who are treatment resistant or who have more complex cases where they may have some multiple types of symptoms. Maybe they have some addictive behaviors as well as a mood disorder, or they may have some form of severe OCD or anxiety symptoms in addition to some other psychiatric symptoms. So I think ideally psychiatrists are probably best suited to be that second line of treatment. And if the primary care doctors feel comfortable with that, which we hope they will increasingly over time, that would be the ideal way to proceed.
Okay. So really the suggestion would be go to the PCP first, make sure that you have a PCP, see how they feel about it. And for the most part, they're pretty good about saying, hey, this is the end of my competence. Like I could take you this far, but really after this point, we really should be consulting a specialist just for like say cardiology or hepatology or anything else.
Yes, and not only that, but the doctor can investigate with some screening tests. For example, 5% of all people with major depression are thought to have a thyroid disorder that needs to be addressed or treated if the patient's going to respond to antidepressant therapy. So doing some simple blood tests and a good physical exam can disclose some concerns that psychiatrists really are not specifically trained to do so in their offices.
Yeah. Okay. Well, so that's how it's supposed to work, right? Collaborative team-based care, where you've got the PCP as the quarterback, and everyone works together, ideally on a shared EMR if you stay within the system, to coordinate, right?
Well, that's exactly true, and it takes us back, which I just want to touch on with our earlier discussion of addiction, because at any given time, probably only 5 to 15% of people with addiction are seeking treatment. 85 to 95% are not seeking treatment at all. So they're not going to see a specialist. They're not going to see an addictions expert. The only place they're going to contact a medical professional is going to be the primary care doctor's office. So hopefully the doctors will become more astute at diagnosing these conditions and doing early level interventions in an integrative care model. I
would be a huge fan of that. I remember a long time ago now, maybe like 7 years, I was doing some research for a presentation I was doing on behavioral health in primary care and addiction in primary care and what that terrain looked like. And I found a couple of journal articles that were looking at addiction training in family medicine and internal medicine residency programs. And what they found was that the average amount of time that a physician was training in those specialties was between 4 and 12 clock hours, not calendar or not like credit hours, like 4 and 12 hours over 3 years, which to me is probably not enough to really understand. But that was the mean, right? And I think 12. It was that to me was mind blowing and really just spoke to a need. But there's so much to learn. There's so much to know that it's hard for anyone. Like addiction, I know is my area of passion. I believe it's yours as well. But there's a lot of other areas that people are equally passionate about. So it's kind of hard to say, well, how much of the time in this training program should go to one area.
That's a good point. And the knowledge base of medicine has expanded in a huge logarithmic curve over the past several years. And so primary care doctors are expected to know more and more. They probably are one of the most stressed out branches of physicians because of these expectations on them. And so the burnout rate of primary care doctors are near the top of the scale of all physicians. So we want them to do these things and feel competent and comfortable, but they're getting tugged in lots of different directions, and particularly in their training programs.
Yeah. I mean, I can't even, as a therapist who does hour-long appointments, I cannot imagine seeing people every 15 minutes.
Or 7 minutes.
Or 7 minutes, or even 7 minutes. I think my brain would come out my ears. Well, so speaking of brains coming out your ears, let's talk about psychedelics, because I think that this is another area where there's been a lot of interesting developments that actually are the exact opposite of your brain coming out your ears, but where they might actually have some therapeutic utility. So we've been hearing a lot of buzz recently, or at least I know I have, around about psychedelic therapy, particularly for things like post-traumatic stress disorder, particularly for depression. So can you just give us an overview? What is going on with psychedelic therapies right now? What should the public know about it?
Well, it's kind of a hodgepodge of molecules out there. So we have what are called classical psychedelics, which are basically your hallucinogenic drugs, and that could include drugs like psilocybin, mescaline, LSD. And these drugs have actually been around in different forms for many years. LSD was synthesized in the laboratory in 1948 and was first tested with human beings in the 1960s, I believe. I'm sorry, Aaron, I'll say this, tested much earlier than that. But became popular with Timothy Leary in the 1960s as a form of recreational therapy. So these are thought to be drugs that are mind expanding, if you will. They open up the mind to experiences that one cannot have in a conscious experience. And in the 1970s, because of the excessive use of these drugs, particularly by the young people in our society, very strict laws were passed to reclassify them as class 1 drugs, same thing as heroin. So they could not be used in medical experimentation. They were clearly illegal and could lead to criminal activity if caught using. So these drugs are still classified as class 1 drugs, but there is some research that's now opened up in Great Britain as well as America. Johns Hopkins University has a center for the study of psychedelic agents now in psychiatric conditions, primarily anxiety, depression, post-traumatic stress disorder. And there are some interesting results coming about in those conditions. Mm-hmm. There's also some talk, as you're aware of facilitation of drugs with psychotherapy, with using empathic drugs. One example would be MDMA. I know when I was in college back in the 60s, we had what was then called MDA, which is a very similar molecule called the love drug. And so people under the influence of this drug oftentimes are more willing to disclose and to talk freely with their defenses down. And it's thought to facilitate psychotherapy as a general intervention with patients. Mm-hmm. Some of that research is showing positive results with these drugs, and will probably spread to multi-center trials in the future. Mm-hmm. Will they basically be opened up? That's going to be taking an act of Congress, unfortunately, because very highly politicized field.
Yeah. Well, and I think it's a really interesting question, right? Because this is an area where people have definitely on the research side been playing by the rules, and they're doing the studies, and Johns Hopkins, obviously highly reputable center. This isn't some like backwater agency that's doing this or just trying to advance some fringe agenda. Like these are legit centers that are doing this work. But at the same time, there are a lot of these structural barriers, as well as some outfits that have been doing this very, very off-label. I remember reading a really interesting story. It might have been in the New York Times, but of these basically these psychedelic PTSD-related retreats in other countries where people would basically go on, very shamanistic in a way, but it would be based around one of these psychedelic drugs to have one of these out-of-body or transcendent experiences, and hope that kind of jars them out of whatever rut their cognitions, their minds have been in, so that they can see their life in a different way.
You're right, and that is probably where most of the reports are coming out of, is these anecdotal studies, often in other countries. When you look at how it's performed in America, for example, using the psychedelics, for example, psilocybin or LSD, you must have a trained individual as a guide with the patient for several hours, probably 4 to 6 hours of the experience. And then you have a second integrative session in which oftentimes the same guide, possibly a different one, will take that experience they had under the influence of the drug and use that to integrate some of their, say, post-traumatic stress issues. Another 4 to 6 hour session, by the way. So how do you charge for these? How do you develop procedure codes? Who's licensed to give this drug? So it's going to be a huge barrier from just a licensing payment centered focus about how this will ever take place. But it's indeed a very intriguing area, and I think we're going to see more of it in the future.
Yeah, I know the part that really struck me as the most interesting was this idea that the mechanism of action per se, so some of it might be, be neurological, some of it might be chemically based, but that a lot of it is just simply this idea that it's very difficult to alter your understanding of yourself or your world from inside your own lens. And so by process of taking yourself literally like out of your body and having this sort of experience where you see your life in a different context, that gives you a frame to be able to change. Like I know for me that there's been folks at times who I've worked with over the years where I've thought, yeah, like that actually, I could understand how like getting this person out of their head for a little while might actually be a huge help.
Yes. And that is a nice way to put it. The pharmacology of these drugs is quite intriguing because they basically access both the serotonin system in the brain, particularly in the frontal lobe, but also the dopamine system in the brain. And so you have an intriguing profile that results in some degree of dopamine stimulation. As you and I both know, that's kind of the center for addictive behaviors also. So people who are prone to have addictive risk have to be particularly careful with using these agents because it may trigger some desire to reuse them repeatedly.
Yeah, and actually, a quick aside on that. In my experience and in my practice, I have not seen nearly as many people addicted to hallucinogens as other compounds and other substances of misuse. Has that been your experience as well, or have you found people with like a primary hallucinogenic use disorder?
It does occur, but it's quite uncommon. So one can take LSD repeatedly, and this has been done in actually experiments that were conducted by the CIA in prison populations, etc. So,
did that get to the IRB? Was this done before?
Yes, it's come out in some investigative reporting, but it was done without the FDA involvement. But so frequent multi-dose use of drugs like LSD does occur, has been used in illicit clandestine studies, and you can develop dependence. But in the general population, seeing people with a hallucinogenic addiction, if you will, is very uncommon. I rarely see it, and I don't think we're going to see a lot more of it in the future.
Yeah. So unless you're you're in like a dark prison, and you're some sort of like spy or you're being acted, you're probably okay. You're probably not going to be addicted, but and not necessarily a reason to go use it. But I would say the chronic use syndrome that I've seen most often has more to do with some sort of persistent hallucinatory experiences, or just struggling with like mild hallucinations that never really seem to go away if someone repeatedly uses psychedelics over time. I've seen that more commonly than addiction.
And that is reported as a specific syndrome in DSM-5, I believe. I know it was in DSM-4 anyway. But this persistent kind of flashback-like experience can happen with some hallucinogenics, probably most commonly LSD. Can be difficult to treat and can be quite anxiety-provoking for people, as you might imagine, because they can come on with a little stimulation.
Yeah. I can imagine if I started hallucinating all the time, that would definitely put me on edge. and make me worry about what I've done. But one more question on this topic before we wrap up for the day. So another phenomenon around psychedelics that I know I've seen articles about online, I heard a little more chatter about, is something called microdosing, or when people take a small amount of a psychedelic, not actually with the purpose of having a dissociative hallucinogenic trip, but with the idea that this small amount of the compound will actually be helpful for things like depression, anxiety, overall sense of wellness. So people will generally take it in the morning and do that maybe like between 1 and 3 times a week, and subjectively report that it helps them in some way. What's your understanding of microdosing thus far? Is there any truth behind this, or is this maybe just a placebo effect on steroids?
Well, it's an intriguing concept because it reminds me of our earlier discussion about naltrexone. That naltrexone at high doses blocks mu-opioid receptors, but at low doses it may have other pharmacologic effects that have therapeutic use, such as endorphin release. We don't really have answers to this yet, so it's premature to state what's going on. But it's a little bit like homeopathic medicine, that low doses of drugs can do different things than high doses can, and may have some utility for a person's well-being and health.
Mm-hmm.
The challenging thing is going to be studying this, Aaron, because of the fact these drugs are all illegal. They're class 1 drugs, and you have to study them over probably months, if not years, in terms of seeing long-term effects, and to see if people actually start misusing the drugs over time.
Yeah.
We know that about 10% to 20% of all people have some hard wiring for addictive behaviors. And so some people might misuse microdosing and start escalating the use. And so doing experiments to find out what's going on here is probably going to occur in the future. And I think we're a few years away from that, though.
Mm-hmm. I know, to me, it also just kind of pushes on this question of like artificial enhancement of humanity. Like, do we say, for example, that it might be helpful, or there's rumors that it might enhance just your experience of life? How do we look at that? This idea that, all right, should you be, or even is there some benefit to being in some state of augmented consciousness or augmented reality all the time? It's just a matter of course, because that augmentation feels better and we're not seeing negative side effects versus just experiencing life as it is.
Intriguing questions, and it gets into the interface between psychedelics and mental illness as well, because we have states like hypomania or mania, in which the person looks like they're on some sort of drug, an amphetamine or cocaine or some form of stimulant. And some people feel they're more creative and more effective when they have at least some milder forms of a manic-like state. So could this be an enhancement form? Hard to say. There was a study done many years ago at the Iowa Creative Writers Workshop, in which psychiatrists at the University of Iowa interviewed and did extensive testing on all the graduate students in that well-known department of literature, and found that up to 70% of them had some form of bipolar spectrum disorder. So here you have a bunch of very creative people who've accomplished a lot and may be driven to some degree by the positive effects of a mental illness that is probably at a low grade and doesn't really interrupt their behavior significantly otherwise, but does lend to creativity. So these are fascinating questions that we hope we'll have answers for in the future.
Yeah, I kind of, as things start sliding more towards being changes in drug policy, where we're seen to be leaning towards creating commercial markets for a lot of different things and delist it, basically making it a lot more accessible. I kind of wonder if you'll start to get almost different cultures and cohorts of folks, and there will be like groups of people who believe that we were meant to be enhanced chemically or in some way, and that really, if someone is not doing that, they're not actualizing themselves. that, these things exist. I'm just, this is me just completely speculating, but I kind of wonder if we'll start to see groups that feel that way.
It sounds like some of the science fiction novels that I've read in the past are coming to be, and we've seen these in space travel already, right? So why not? They could happen in evolving human behavior.
Well, right. Well, so we'll have the chemical group, then we'll have the cyborg group, or doing their cyber, like the going down the RoboCop arm. Well, all right. So we're coming off the rails, and we're also at the end of our hour. So to finish things up, is there anything that you'd like to end with, or to present to the audience, a takeaway, something that you'd like to end on today?
Well, I think of all the things we've talked about today, the one that I hope people take home with them is on mass depression. Because these are people who suffer greatly. They have high suicide rates. There's a condition called atypical facial pain, which has perhaps one of the highest suicide rates in all of medicine. And could these be people who are truly depressed, but they're presenting in their physician's office with somatic complaints, and they don't want to see a psychiatrist? So how do you work with these people and who don't want to take a referral, say, to a mental health professional, when they suffer from a psychiatric illness and can be effectively treated if properly diagnosed?
Yeah. Well, it's a tricky question that I know we certainly can't fully answer today. I know that dealing with that is something, though, that is why, in my opinion, we're starting to shift our nomenclature from mental health to behavioral health, because the moment you move away from the word mental or psych, or those sorts of things, you start to chip away at the stigma. I think that getting rid of this stigma would be better, not doing a workaround, certainly.
Right.
But in the meantime, it's definitely a huge problem. But thank you so much for coming today, sharing your expertise, sharing your opinions. If folks would like to tune in again, I think we'll be having another show soon. Love to have you back. In the meantime, Dr. Tees, thank you again. Have a great afternoon, and thanks everyone for listening.
My pleasure. Thank you.